Welcome, everyone. I'm Dr. Justin Morse, and thank you for tuning in for this week's episode of Eternal Vitality. In this podcast series, I talk about all different types of medicine, namely anti-aging, health optimization, and even sports medicine. I have a practice in South Florida that is called the Osteopathic Center. I am predominantly in Miami, but sometimes I go up to the Jacksonville office as well. We do a combination of high-level regenerative medicine, sports medicine, that involves PRP or any of the different stem cell lines, as well as a fully integrative clinic that deals with patients that may have cancer, heavy metal poisoning, mold toxicity, mitochondrial dysfunction, Lyme disease, different iterations that can cause a lot of problems. So I am no longer in the traditional medicine field. I have ventured into the no longer taking insurance because I like to see my patients on my time and spend an hour to an hour and a half with each patient as opposed to 5, 10, 15 minutes and having insurance tell me which tests to order and which treatments are available for that patient. Now, today I wanted to talk about a very important, very common topic we see in sports medicine, and that is rotator cuff tears. Now, last week I talked about shoulder injuries, but more specifically shoulder dislocations and injuries to the labrum. This week is a much more common topic. Rotator cuff strains and sprains and partial tears are very common, anywhere from 30 to 70% of the population are going to deal with this at any given time, especially as we get older. Now, the presentation is commonly pain in the front or top of the shoulder, as well as sometimes instability. You will have anywhere from 30 to 70% of all shoulder pain is associated with rotator cuff tears. This causes a weakness to your shoulder, making normal activities such as brushing your hair or getting dressed much more painful. I often ask patients, how challenging is it to, with this injured shoulder, grab a gallon of milk or a bottle out of the top shelf of the fridge? If they say, nope, I can't do that, you have a problem. If you can't get comfortable sleeping at night because you can't figure out where to put your arm because it hurts, you likely have a rotator cuff injury. Now, these are pretty much all we have when our arms are extended. Think if your arms are close or it's back and we have core. But once our arms are extended and our elbows are out, all we have is rotator cuff. So if you're here, the rotator cuff and shoulder have so many different ranges of motion, and each of them have a job to do when you're trying to do that. I often like to describe a rotator cuff injury almost like a drawbridge. When the drawbridge is up, everything is tight and good, but as that drawbridge extends, you start to have significant stress on where that tendon attaches to the bone. That's usually its area of weakness. The problem with rotator cuff tendons, and really any tendon in the body, is that we don't have any good blood flow to the area. So think of it as a rope attached to a dock, and maybe the dock is holding on a boat. The boat would be the bone. The boat would be your arm. The rope would be the rotator cuff, and the dock would be the bone. That dock's not going anywhere. That rope is trying to stabilize that, the movement of the arm, and a lot of times it starts to fray. So the more it frays, the more pain you feel. Chronically, as it starts to fray, it can't handle the same stress, and eventually it starts to tear more. Then you can have a partial tear or a full thickness tear. Now, sleeping is usually what prevents people really from coming in, whether they're going to a traditional ortho or someone like myself. You have shoulder pain. Some people describe pain down the side of the arm, even though the injury is up top. And you can even have weakness. If you do have radiating pain past the elbow, it is not from the shoulder. It is likely from the neck. Now you can have pain in the front, down the side, on the top, or even posterior. All of those are possibilities for rotator cuff tears. Now, the anatomy of the shoulder is a ball and socket joint. It fits really well, but you need the rotator cuff to hold that ball in the socket. You have a labrum that is on the inside, and then a capsule that is thick around the outside. There are 4 muscles that really span across the joint, or a group of 4. The rotator cuff is its own self a group of 4. Then you have the biceps tendon, long head, short head. You have deltoid muscles, which are on the top, anterior, central, and posterior. Then you have the pec minor and major, as well as the rhomboids and serratus in the back. So there's a lot of moving parts to that shoulder. Now, the rotator cuff is built of 4 predominant muscles. You have the subscapularis, you have the supraspinatus, you have the infraspinatus, and then you have the teres minor, which is in the middle of the back. Now, there is a lubricating sac in between the acromion, which is the tip of the shoulder here, and the rotator cuff underneath it, that allows for freely gliding of the tendon. The shoulder, the rotator cuff essentially allows for attaching of the humerus to the shoulder blade and helps to lift and rotate your arm. Depending on which way you're moving will depend on which one is in use. If the rotator cuff tendons are injured or damaged, or the bursa becomes inflamed or painful, you can have issues and you won't want to do it in that manner. So you may, instead of doing it like this because it hurts, maybe you do it like this or like this. Oftentimes this is our dominant side, but it can very well be both sides. Let's talk about each tendon individually. Now, the subscapularis is very important. This one is in the front of the shoulder and is, I like to describe this maneuver as almost like a seat belt where you go across your body. And it has a spring-like motion. This is one of the important muscles that we use for throwing. It helps to attach the front of the shoulder to the front of the shoulder blade. And injuries often associated with the biceps tendon. And a lot of times people think, oh, I have tendinitis. It's usually an injury to the rotator cuff tendon, not the biceps tendon. The biceps tendon just kind of comes along for the ride, is more annoying, but is a symbol saying, hey, there's something else going on. You can have discomfort in the front of the shoulder. You can have weaknesses in activities engaging, such as lifting, twisting arm, or even different types of sports. Some people even have popping and clicking while they're rotating, and that's usually the tendon trying to rotate and not able to do so without pain or without discomfort. Now, there's a couple ways to test this. The most common one is I have someone put their hand on the middle of their back. That's usually painful in its own right, and then I have them try to push me away. Usually, if they have an injury to the subscap, they cannot do this, or it's very painful. The other thing is I'd have them kind of bear hug their opposite shoulder, the healthy shoulder we'll call it, and then I usually try to lift off. If they can hold it down, the subscap is probably in good shape. If they can't and it's easy to pull off, then the subscap is probably pretty beat up. The last one, that also an easy one, is you can put your hand on your belly button and try to pull that person's hand off. If they can pull it off, then that usually tells me the rotator cuff is beat up. Now, the next one we're going to talk about is by far the most important, and this is called the supraspinatus. The supraspinatus is, if I had to guess, this is the one you injured. Because we use it because of the range of motion, this is responsible for here, 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 up here, over here. Like, this does pretty much everything out in front. And as a result, we really, really have a tendency to injure this. Now, this is the most common injury for both men and women in the rotator cuff, 62% in the men and 38% in the women. 70% of people over the age of 80 have a tear in this. I'm surprised it's not even higher than that. As I mentioned, this, in my opinion, is the most important rotator cuff because this one stabilizes the shoulder and is responsible for so many different things that we do out in front and overhead. If someone can't do something out in front overhead, it's usually an injury to the supraspinatus that causes it, or oftentimes a combo with the subscapularis. Now, the most common test for this is what we call an empty can. So think of you pouring out a can with your thumb down. If this hurts, then there's usually an injury to the supraspinatus. The other one that is really sensitive, it's called a hug up test. So basically, you reach your hand across, and then the doctor or person evaluating is going to push down that elbow. If that hurts or is just drops like a rock, then there's an injury to the supraspinatus. They also have something called a Neer or a Hawkins test that helps to evaluate for impingement, and is about 75 to 88% sensitives for a supraspinatus tear. Now, the infraspinatus is the largest of the rotator cuff muscles. It is in the back and basically attaches to the whole top of the posterior shoulder blade. It is a huge external rotator. So think of putting your arm outwards. So if you're trying to test for this, you're going to basically prevent, and can I push through it? If I can push through it, then you're strong. If the tester pushes on that and the patient can't move that, that means their external rotator or their infraspinatus is beat up. This usually does not cause a lot of pain. It's more weakness. Sometimes it can be confused with the supraspinatus or even what we call the posterior capsule, which is the back part of the shoulder. Now, the last one that we often don't talk about much, but is technically part of the rotator cuff, is the teres minor. This is a small little muscle that's narrow, long, and attaches the outer arm to the lower part of the shoulder blade. And there's a very similar muscle that's much larger underneath it that's called the Terce Major, and that's part of the back. This is responsible for laterally rotating the arm as well as stabilizing the humerus, and is just inferior or below the infraspinatus. Those are the 4 main rotator cuff tendons. So there's 6 different types of injuries that you can have for this. You can have for any of these. You can have an acute tendinitis, which is acute inflammation, but no chronic changes to the tendon. Whereas if you have chronic inflammation or chronic injury to the tendon, it usually changes its structure. It's called tendinopathy. I like to describe this as almost like, think of a normal tendon as beautiful lanes, straight lanes on a highway, and now you have all these crisscrossed highway roads that don't make any sense, that are no longer straight. That's kind of what happens with chronic injury to the rotator cuff. You can have an acute tendinitis on a chronic tendinopathy. That's usually what happens as we get older. Now, if you start to injure the tendon so much so that, say, it's an inch wide and now it's only a half an inch wide, meaning you've torn 50% of it or 25% of it, that would be a partial tear or a grade 2. Now, sometimes what happens, because the tendon is under tension, then sometimes it will roll up after being torn, and that's what we call retraction. Almost think of like a tape measure, and when you put it up, it rolls up into that spool. That's kind of what happens. And the problem is, once you've torn it and it's regressed, there's nothing you can do about putting it back unless you have surgery. That's a bad indicator of a moderate to severe disease for a rotator cuff injury. Now, you could have a partial tear of the upper third. You could have a partial tear of the lower, meaning closer to the bone. You can have a complete tear of half the tendon, of the quarter of the tendon. You could have a complete tear of the entire tendon, meaning it's no longer attached to the bone. That would be a full thickness tear, grade 3. Those are bad. Those always require surgery because there's nothing attached. You can also have associated labral tears. You can have biceps tendinitis. You can even have a frozen shoulder, which you've probably heard of before, literally insinuating that the shoulder cannot go higher than a certain degree. It's a combination of pain and decreased range of motion. Can last up to a year and a half. Now, as I mentioned, there's basically 3 grades. Grade 0 would be normal, no injury. Grade 1 is mild. Grade 2 is partial tear. Grade 3 is a full thickness tear. Now, what are the risk factors for recurrent injuries? You have older age as the strongest risk factor. It's 336% higher likelihood as we get older. Now, male has an 87% ratio compared to females. Smoking, 221% increase. Diabetes, 167% increase. High blood pressure, 151% increase. You can also have issues with high cholesterol, with trauma, as well as family genetics. Now, imaging. People often ask, what is the best form of imaging to check for a rotator cuff injury? And the answer is actually not very simple. First of all, the patient telling you their history is the most important, as well as the physical exam that I just mentioned. In several of those, you can get a very good idea of the extent of injury just based on physical exam. Ultrasound is more sensitive to rotator cuff injuries. You can see everything right underneath the skin. You just have to know what you're looking at and be able to get one. But they are very, very sensitive. Oftentimes, we complement an ultrasound with an MRI because the MRI will tell us, is there any injury to the labrum, any injury to the capsule or to the articular cartilage, and if you have any retraction. So that oftentimes I will use both. if oftentimes they might underread the rotator cuff injury on an MRI, but you can see everything clear as day on a rotator cuff ultrasound if you know what you're doing. Now, ideally, if I'm ordering an MRI, I'm going to order a 3 Tesla, which is the strongest one. You just have to ask the place you're getting at, what's the strength of your magnet? They usually have 1, 1.5, or 3. Ideally, you go for a 3. They don't technically cost more, but they are way better quality. And you can do this with a 3 Tesla without contrast, because then that's just one less issue that your body has to deal with, trying to clear that contrast. Now, treatment options. Let's finish fast and strong. Do all rotator cuff tears require surgery? No. It really depends on the severity and associated injuries. If you have a labral tear, if you have arthritis, if you have what we call a Hill's fracture or a fracture, then that obviously will indicate, hey, I can get away with it. No, I don't need surgery. Or yes, I really need surgery because I can't. Everything else has failed. Now, activity level of patient will be very indicative as well. If you are a high level athlete and you have a partial thickness or a full thickness tear, you're going to have to get it repaired because you won't be able to function appropriately unless you really throw the kitchen sink at it with regenerative medicine. But regular people, most of the time, you can get away without a repair unless it is a really bad tear. Now, you could do your anti-inflammatory, something like tramadol, but they're really just helping with pain and not really helping with the tissue at all. Physical therapy does a fantastic job for these, but sometimes you start to plateau, and that's when you need a little extra help. And I'll tell you about that in a sec. Some people will get a cortisone injection into this area. This is not an ideal situation. You can calm down the inflammation in bursitis, but it is not going to strengthen up that tendon, although it may and likely will help with the pain. But you should do something along the lines of physical therapy, regenerative medicine, or eventually consider even surgery if that rotator cuff is still not improving and the pain is still not improving with that cortisone injection. I personally do not do them anymore. Now, regenerative medicine, or AKA stem cells, is becoming very, very popular. This is my personal specialty. There are a couple different things you can do for the shoulder that work really well. If you have a minor strain, you could do something called prolotherapy. This is a mild irritant to the tissue, making a combination of lidocaine and dextrose that helps to tell the body, hey, you have an injury here, go to work. Now, this is not super strong. About 33% is potent as PRP, but it is potent and you can do it, and it works well. You can do it once a week for a couple, 3, 4, 5 times, and that may be all you need, and it's relatively inexpensive. If you have a partial tear or a decent injury, then you probably want to jump up to a PRP line. That's platelet-rich plasma coming out of the blood. I will refer you to an older podcast episode where I did a deep dive into PRP. But in general, we're taking your blood out, getting the growth factor-rich layer, then spinning it, optimizing that, sometimes photobiomodulating that, and then injecting that into the rotator cuff, directly into the injury, ideally under ultrasound. The stronger the PRP and the more volume you put in, the better the result. So when someone tells me they put 2, 3, 4 cc's, you're not likely to get the results you're looking for. And you also ideally want to put it not only in the injured tissue, but also in some of the areas that are trying to compensate to really stabilize the whole shoulder, not just a little bit. Now, if you have a partial tear of the rotator cuff, maybe you have an injury to the labrum as well, then PRP is usually not going to be strong enough. What we've learned is that you kind of have to incorporate a stem cell line or orthobiologic, whatever you want to call it. So you have bone marrow coming out of your hip, you have adipose coming out of your fat. Both of those has fantastic stem cells, and you also have donor grafting that is available in some parts of the world. Those are amniotic tissue, Wharton's jelly taken from the actual umbilical cord, or even placental grafts and different things called exosomes that can help. So all of these are super potent. A lot of the times they will mix and match these with PRP to kind of come up with a beautiful combination to inject right into the tissue and to help solidify it. Now, surgery is obviously an option, and if someone only has a partial tear or a full thickness tear and it's isolated, then they may do an isolated repair, but this is not a quick journey. We're talking minimum 3 months, probably closer to 6 months to return. This is a rough journey. Now, if you have a rotator cuff tear, have a bad labral tear, you have bad arthritis, a lot of the times they'll just end up replacing the whole joint because it ends up being more effective than just doing a little area and then you have another injury that just doesn't cause the pain to go away. So hopefully you found this interesting. I did this one very quickly, but I wanted to make sure that you understand that these are fixable with just physical therapy. Sometimes you do need a regenerative medicine injection, but sometimes they're bad enough where you do need a repair, but that would be my last resort, in my opinion, because sometimes you can even tear the repair, and being in a sling for 4 to 6 weeks after a surgery is not ideal. Some people even get issues with frozen shoulder or other related injuries in there. So I prefer the non-surgical route, but sometimes it is called for surgery. I hope you found this helpful. Check out some of the other podcasts that I've listed. We'll be back next week with a new and exciting topic. Please put some comments below of what different things you'd like to hear. Share this with your friends, and maybe do me a favor and leave a 5-star review on your favorite podcast place. Thank you very much. Take care.